PD COMM aims to provide high-quality evidence about speech and language therapy for people with Parkinson's disease. Through PD COMM, we are investigating two types of therapy: Lee Silverman voice treatment and other standard NHS intervention. PD COMM is a UK multi-centre randomised control trial. It is funded by the National Institute for Health Research Health Technology Assessment Programme. 40 PD COMM sites are supported by our trial team at Birmingham Clinical Trials Unit, King's College London, Bangor University, University College London and Glasgow Caledonian University. Gillian Beaton is a PD COMM speech and language therapist from NHS Greater Glasgow and Clyde. As she was also involved in the PD COMM pilot study, she came in to talk to us about her experiences.
So Gillian, you were involved in the pilot of PD COMM as well. Why did you particularly want to get involved with this trial?
We were already seeing people with Parkinson's and delivering LSVT as a service. So we used to audit our caseload every year, and so out of 200 patients that we had seen, 33 had LSVT. So really this trial just gave us the opportunity to look at how effective LSVT is versus randomised NHS treatment, because there are also patients who, for one reason or another, can't commit to LSVT, and so it was very interesting for us to consider what the effectiveness was of a less intensive intervention.
So you're used to, obviously, people are referred to you, so they've decided they want to be referred, and then you discuss with them what kind of intervention might be best for their needs. So how did you cope with this idea of randomisation, and did it throw up any surprises?
Yeah, that was quite interesting, because you in some ways do feel a bit disempowered as a therapist, because you're used to seeing a client, discussing the options with them and deciding together what's best. And so here you are with this person coming in who's maybe already been randomised to LSVT that you don't know, and so you would sometimes feel like a bit worried and interested, I guess, to see what would happen, because you weren't making that therapeutic decision. But we had one very interesting man who was randomised to LSVT, whom I shared delivery of treatment with my colleague, and my colleague saw him on the first initial assessment, and then I was doing the next session, and she said, "Oh, I would never have randomised this gentleman to LSVT." I then met him and felt the same, so we thought, okay, well, we'll go through the first week and we'll see how we both feel and how the patient feels at the end of the first week. And he turned out to make amazing gains. He embraced intervention. He got 3 buses to clinic. That was one of our issues, was like, how is he going to do this? So he managed to attend the sessions and made such gains in intervention that really made us realise that sometimes it's good to have your clinical decision making questioned, because we learned a lot from that.
And you mentioned there that you shared a patient, because LSVT is 4 times a week for 4 weeks, and a lot of speech and language therapists are part-time. So what were the other kind of service delivery challenges, if you like, that you had to take into account for the trial?
Well, we do have staff who work part-time, so we always had to make sure we were ready to deliver intensive intervention, and sometimes we had to say to the participants that they may have to travel to a different hospital, or maybe somebody was going to be on annual leave, and so they could have 3 sessions in one hospital, but maybe for one session of the week they might have to go to a different hospital, and that was explained to the patients at randomisation by the research nurse, and that seemed to work okay. We just had to plan, we had to be prepared. But what we did find, that our biggest worry was that every participant randomised would be randomised to LSVT, but actually that didn't happen, and during the pilot our first 6 were not randomised to LSVT. So I think we had control, NHS, control, and then finally we had an LSVT participant, and we were almost wishing for an intensive option to come along, because we just felt we weren't getting started. So that made us realise that actually we didn't need to panic and worry so much, because with the law of averages, it is unlikely that you're going to have several LSVT participants at the same time.
And the LSVT is obviously quite prescribed, what you do, but standard NHS isn't. So how did you, as a team, how did you decide to deal with that?
Yeah, during the pilot we met as a team and discussed almost like what would we do, and trying to for some of us who have been trained in LSVT, it was hard to remember what we did before we were trained because of using the principles. So even if patients weren't able to attend intensively and we were delivering a more standard type of intervention, we might still use some of the principles. So we tried to unpick that a bit, and we just kind of revisited some of the therapy techniques that we might have used before, and in some ways it was quite good to try different things again. And we tried not to have too much of a loud emphasis during the pilot, but during this existing trial if we do have an NHS treatment patient and we feel that that's appropriate, we would still use that sort of type of strategy with the clients. But the thing that you'd asked before about how you felt about decisions being made for you, and I know that at some points in time when we had an NHS standard treatment patient that we almost felt a bit frustrated because they were ideal for LSVT and they would have been able to attend intensively, and so sometimes that was a wee bit frustrating because you thought, oh, this person would be ideal for intensive intervention. But then the other side of the coin was it was really interesting to see the results with those patients because they themselves were really positive about their intervention, and again they made gains. So yeah, it gave us a lot of food for thought.
And the whole control thing, if you're going into a drug trial, for example, and you're randomised to have a drug, you don't actually know if it's the active drug or if it's a placebo. Whereas in a trial like this where everything's quite open, the people who are offering the intervention and the people who are receiving it know which arm they've been randomised to. How do you think you get over this issue with people, this fear, if you like, of people being randomised to control?
I think it was really just trying to guide or asking the referring clinicians to ensure the patients that at the end of the time period they will get whatever they need, but also if their needs change over the time period that they can drop out of the control arm and be offered intervention, and also that if they had any swallowing needs we can see them anyway. So I think it was just trying to reassure people that if things change that they will be seen.
And of course you're into this, it really is the patient's choice, isn't it? At the end of the day they have to be given the option. So that kind of leads on to how have you found that people have responded to the idea of the trial, to being part of it? Has anything surprised you?
Yeah. I think people who've wanted to be part of the trial have been really committed to it and really interested in feeling like they're giving something back. I know I had one patient who really swithered over whether to participate or not, but had been watching a TV programme about health research and therefore decided, no, I'm going to do this, it's important, and he felt kind of quite important. He said that I've really enjoyed that, I've learned so much, and even said, what training is it that you do as a speech and language therapist that you found that was quite interesting and more involved than he ever imagined it would be?
And the whole, from the point of view of the profession, do you see this kind of study as being important?
Yeah, absolutely. I think we don't have this level of evidence, and I think it is really, really important to be looking at that because we see a lot of people with Parkinson's and we should be delivering the best care to them, but maybe we will find out that there's more than one option that is effective. I think it's really good to look at delivering LSVT within the UK because a lot of the research has been done in the States, so I think it's really good to have a trial in the UK within our NHS system.
As a speech and language therapist, is there anything that you get out of being involved in the trial?
I've learned so much about research that I didn't know before. I think the trial team set up really good study days and learning opportunities, and I've really gained from that. I've also had the opportunity of writing up a single case study, which was the gentleman whom we thought would not benefit from LSVT, and was able to present that at the college conference, and PD COMM trial helped to fund that for me. And I think it's just opened learning opportunities, but it's also helped me to reflect a lot more about my practice, and also, I guess, developing like a wider network of clinicians who work with people with Parkinson's, and just having like a wider network of people to contact if you have a query or you're interested in doing something different. There's definitely a lot going on out there that we don't know about, so it's just a really ideal opportunity to share practice as well.
Is there anything in particular you'd like to say to speech and language therapists who are swithering about being part of the trial?
Yeah, I would say just give it a go, just try it. That it does take planning, it does take preparation, but it is worth it to be involved, and you will gain so much as a service out of being involved, but also your patients will gain too, and it's just really valuable trial to be part of. So just try.
Great, thank you very much.